Good afternoon, everyone. Welcome to the 2025 Public Health Symposium. It is my great honor to welcome all of you here this afternoon. Mayor Sullivan was here, but he had to take his son to a college tour, a high school tour, and so therefore he gave a brief presentation and move on. But we welcome you all here this afternoon to this symposium. I think it's long overdue. We had the last one about 3 years ago, and we have some of the folks who participated in the first one here with us. And so it is a great honor to have you here this afternoon in the City of Champions, as the mayor would like to say. And we have a very full agenda, but we did have a technical issue with the sound system. As you know, sometimes you can prepare, but plans can go a little bit on the wayside. So we welcome all of you here. We have some data that we're going to share with you. That's the data that we have collected for 5 municipalities: the city of Brockton, the town of Avon, the town of Abington, the town of Stoughton, and the town of Whitman. I am Ino Mondesier, the Executive Health Officer for the City of Brockton. And again, it is my great honor to be here with you today. And we will be presenting some dignitaries and the elected officials, and also the colleagues from the state health department. And as of now, I would like to present to you Burke Steinman, who works for Moxley and Moxley Public Health, and who also conducted part of the team who conducted the community health assessment for the 5 municipalities. As you can see, we have PN5, which stands for Plymouth and Norfolk counties. And then the 5 is for the 5 municipalities. So without any further ado, may I introduce to you Burke Steinman.
So just really quickly, a little bit about Moxley Public Health. We are a public health consulting company, and we specialize in community health assessments and community health improvement plans. We are all women-owned and operated, so we're really proud of that. And this is our wonderful team. As you can see, we are small, but we're mighty. And if you all want to, you can scan this QR code, and it'll take you directly to the full community health assessment. So today I'm going to go over briefly some of the larger findings and go through each health need. But if you want to view the full report, hopefully this is big enough on the screen. If not, maybe we could send it out after. But if you want to review the report, the entire over 100 pages worth of data, feel free to scan that QR code. It'll take you to the full report. So one thing that's really important to us at Moxley Public Health is that we want our community health assessments to be used. And so that's one of the most important things when you're viewing our reports or looking through this data. When it is more like graphically forward, and that is one of the reasons why we make it beautiful and make it very like graphic design, is so that it's used by the community. So the last thing that we want is to collect all this data, spend months and months partnering with PN5 and going through all this data, and the last thing we want is for people to not use it. So what we really try to do is make our data really easily digested. So when you're viewing our slides today, hopefully that comes across. And if you're not familiar with the community health assessment and community health improvement plan process, I just kind of want to give a zoomed out overview just so you have a little bit of context when we're going through this report. So a community health assessment, basically Moxley Public Health collects primary and secondary data. So the primary data will be our focus groups and our key informant interviews. And then secondary data is data that already exists. So from county health rankings or the CDC. And then we'll do a bunch of data collection to create the community health assessment. Moxley Public Health and PN5, we then review the results of the CHA and decide on the priority health needs. So the priority health needs are pieces of data that really stuck out, or priority populations that we feel like we need to address. And then from there, we move on to the community health improvement plan. So a community health improvement plan basically takes the priority health needs and figures out a strategic plan to address those. So just a quick overview from community health assessment to a CHIP. And when I say CHAW or CHIP, it's community health improvement plan and community health assessment and community health improvement plan. So the purpose of a community health assessment or a CHA is really to tell the story of the service area and from a health perspective. So it really helps us look at the community as a whole, try to identify those unmet health needs and the disparities in the community. And it really serves as a basis for when we create that community health improvement plan. So overall, the purpose of a CHA is to collect the data and present it in a easily digestible way, an understood way. And then we move on to the community health improvement plan, which takes that data from the community health assessment and basically creates a strategic plan to address those priorities that were laid out and shown in the community health assessment. So that's just a quick overview of what a CHA to CHIP process looks like. Now I'm going to quickly go over the 2025 CHA findings. So, like I mentioned, a community health assessment is made up of both primary and secondary data. And for PN5, we conducted 49 key informant interviews with community leaders and 12 focus groups with a total of 139 participants. Just in the focus groups, that is exclusionary of the 49 KIIs. And then we combine that with the secondary data, and that helps us create our CHA. For our key informant interviews, you can see a full list of the sectors that we wanted to make sure were represented. So these are all listed out for you, but one of the most important things when we're doing our key informant interviews and focus groups is making sure that we get a sense of the whole community. So that's why we conduct a lot of focus groups and a lot of key informant interviews, is so that we try to get to the root of things. We want to see if there's health disparities, if there's unmet needs, if there's certain populations that don't feel that they're being heard. So that's why we do a large array of community health, key informant interviews and focus groups. So these are the sectors that we focused on for key informant interviews. And then for focus groups, we had 13 focus groups. And something to note, like Dr. Mondesir said, PN5 has 5 towns or cities in it. So we made sure to have focus groups in Abington, Avon, Brockton, Stoughton, and Whitman. So we really tried to make sure that when we were doing this community health assessment that we were viewing the community as a whole and really trying to figure out those needs that we need to meet. The community health ranking. So our reports are organized by community conditions. So you can kind of relate those to the social determinants of health, and then health outcomes, which are kind of results of your community conditions. And the way that our report is laid out, if you scan that QR code, you can kind of see it already. But they are ranked, the community conditions and health outcomes are ranked based off of our primary data collection. So for focus groups and key informant interviews, the number of mentions that each community condition or health outcome had, the more that they had, the more that they were discussed in focus groups and interviews, the higher that they got on the rankings. So when you're looking through the report, it is organized by what the primary data collection is saying. So we really want to bring what the community is saying and bring that to the forefront of the report. So when you're viewing it, know that that's the primary data collection that made those rankings. It's not secondary data. And this is our kind of a report structure. So before you get into the data on the health needs, we really like to define our service area. So for PN5, you can see that it's made up of Plymouth and Norfolk counties, and then the city or towns. And then each town or city will have an at-a-glance page. So this really just kind of goes into the demographics, and each town or city has one of these. And so if you're viewing the report just for your town, you'll have your own demographics laid out here. So it really just like kind of gives a context of the report and before you get into the data. And then lastly, before I get into the results, the way our reports are laid out. So this is an example of a health need that we will assess. Each part of the report has secondary data here, and then all reports or all community conditions have community feedback. We identify priority populations, and we also identify top issues from focus groups and interviews, subpopulations that were most affected, by each health need and top resources that are being used. So each health need has these different sections. Okay, now we're getting into the actual results. First off, access to healthcare. So this ended up being one of the priority health needs, as I mentioned earlier. And two big findings that we found here were access to healthcare. It was the physical access as well as the financial aspect, which created a barrier to healthcare. So on the left-hand side of the screen, you can see this is the primary care physician ratio and the dental care provider ratio. And you can see the differences between Norfolk and Plymouth County and then the state. And just as you're looking through the report, whenever it's Plymouth and Norfolk County and not the towns, it's only because that was the data that was available. So when we do get to city level data, it's always wonderful to have it. But if you do see Plymouth and Norfolk, it's just because we couldn't get city, those data points for the city or town level. And then our second finding when it came to access to healthcare was the financial component. So the barriers are the things that prevent people from getting healthcare. And the biggest one was financial. So you can see whether that's prescription medications, health insurance being too expensive, or the financial strain that getting healthcare has on an individual. Those were the two most prominent things that came up, was the financial and also the physical access and the ratio of providers that are close by. Nutrition and physical health. One of our biggest findings here was the physical inactivity, and although it is pretty on par with the state, we always like to look at that. But one thing that was interesting when that came up in focus groups and interviews was actually technology, electronics, and TV, and how that affects the activity and really increases the sedentary lifestyle. So that came up multiple times. And then of course, for nutrition, the fact that unhealthy food is cheaper and healthy food is more expensive. So not being able to afford healthy foods came up as a big part of the nutrition aspect. And then income, poverty, and unemployment or employment. So something I wanted to bring to your attention here, which is when we have the city level data, we always really like to look very closely at that. And so for example, one of our findings here for the low income rate at the city or town level was that Abington had the lowest income or the lowest rate of low income households, and Brockton had the highest. So and then when we're looking at these, I like to sometimes use the state, or when you're going through the report, you can use the state as kind of a data point to look at. So you can see that the state of Massachusetts 9%. And it kind of gives you a reference point. So you can see that Abington's relatively low and Brockton is higher. So you can see those are an interesting contrast. Housing and homelessness. The biggest thing that came with housing and homelessness was limited affordability and just a lack of housing in general. We had a lot of focus groups talk to us about how they don't feel like their salaries are enough to afford rent. Because their salaries aren't enough to afford rent, they have trouble buying homes. And so that was something that came up a lot, was just the affordability and also the lack of access. And particularly what came up a lot was in the seniors or older adult focus groups. This was a reoccurring theme that it was a big concern among older adults. And it also came up significantly in the Abington and Brockton focus groups. And I know I'm going through these quickly, but if you do have the chance to look at the full report, we would love for you to look at it because there's just so much good data. These are just such brief points. But just when I'm going through this quickly, know that there's a lot more to each health need. Education, the biggest thing we found when it came to education was a concern across key informant interviews and focus groups was the effect of mental health and the when youth are struggling with their mental health, it affects every aspect of their life, but this was a reoccurring theme when it came to education, is that mental health can affect chronic absenteeism, suspensions and expulsions, and just their education in general. So that was a reoccurring theme across almost all of our focus groups, was just the concern for youth mental health. And so particularly when it came to education, Although you can see on the left-hand side when we're looking at the Healthy People 2030 targets, some of the towns or cities don't necessarily meet them. The high school graduation rate that we want them to meet for the HP 2030 targets, but they're very close. So although that, that is the data point that you can look at, what we found, what was the most prominent in our primary data collection was the concern for youth mental health. Food insecurity. One thing I wanted to point out here was the SNAP utilization rate. So again, this kind of mirrors the low income rate. So that's why we love when we're able to have the city or town level data. You can see that, again, Brockton had the highest rate of SNAP utilization. So that's Supplemental Nutrition Assistance Program. So Brockton had the highest rate of SNAP utilization. And you can see that again, Abington was very low. But also Whitman here also had a lower SNAP utilization rate. So this is something that when we look at the low income and SNAP utilization rate, you can kind of see that they're mirrored in the cities or towns that the low income rate's higher. You can see that the SNAP utilization is higher. And then pretty similar to the nutrition health need, food insecurity was really highly talked about or related to the high cost of living and the high cost of groceries. So people are feeling food insecure because of the high cost of groceries. And again, the healthy groceries are going to be more expensive, and cheaper foods are going to be probably the unhealthiest. So those were just reoccurring themes when it came to food in the focus area or the focus groups and key informant interviews. Adverse childhood experiences. This came up a lot when it came to, again, youth mental health. So it was less of the concern about how, not necessarily that the PN5 service area had higher rates of adverse childhood experiences. It was just that there was an overall concern about the effects of ACEs. So like I said, not necessarily higher rates, but it was a concern about how ACEs affect education, youth development, trauma, their academic performance, and then if they are experiencing mental health issues because of ACEs, it's if they have, also there was concerns of if they have access to care after that. So this was like kind of multi-layered, it kind of combined it a lot, but overall the concern is just that when kids are experiencing ACEs, people had a general concern that they wanted them to do better and that more things were going to come if more ACEs were experienced. Transportation. The biggest findings for transportation was that the community, there's no public transportation. So that just came up as a reoccurring thing in that there's no public transportation, so it's hard for me to get to X, Y, and Z. Or one of the biggest things that came up was when it comes to the health of the community was that there's no transportation, or people felt that there was not enough transportation to medical appointments. So this came up a lot in the older adult focus groups. So the people who needed to get to the older adults who needed to get to their medical appointments, if there wasn't public transportation, they struggled to find a way to get to those appointments. So this particularly came up in older adults, and transportation was actually ranked as a top concern in focus groups for Abington, Stoughton, and Whitman. Preventive care and practice. This kind of relates to transportation in that among older adults in our focus groups, preventive care, they felt kind of that with a lack of transportation, not being able to make those primary care appointments or go for those preventative measures. For example, if the local drugstore who's giving you a flu shot, you don't have transportation to get your flu shot, then you're probably not going to get your flu shot. So just like small things that add up like that. So transportation to appointments was a big factor for older adults. And in general, across key informant interviews and focus groups was just the concern, just for the lack of education. They felt like there could be more education when it comes to preventive care and practices. Internet access. Internet access didn't have too many significant findings. One thing that did come up in a couple focus groups was obviously that internet is expensive. Good internet is expensive, that's reliable. And for some people brought up that If you don't have reliable internet, then you don't have access to telehealth. So that was just like a smaller finding in that a lack of internet access can actually decrease your access to healthcare. So although this didn't come up like overwhelmingly, wasn't an overwhelming problem that people kept talking about, it did come in as telehealth was something that really can increase access if you have access to internet, but if you don't, then, or don't have reliable internet, then it can be a problem. Crime and violence. Crime and safety was a top concern in a lot of the communities. It was most frequently mentioned in Brockton focus groups. And the top issues when we were talking about crime and violence was domestic violence, substance misuse related incidents, and car break-ins. So it wasn't like people were frequently mentioning it, but it did come up as a topic of conversation. Environmental conditions. The biggest finding when it came to environmental conditions was that people had concern about the water quality, particularly in the focus group for Abington and Avon, and it also came up in interviews for Brockton, just that the quality of water, the taste of the water, so that came up, was a reoccurring theme when it came to environmental conditions, but there weren't any other environmental conditions that came up reoccurringly. Access to childcare. This was probably a little bit obvious to all the parents who are here, but childcare is expensive. And that was honestly one of the biggest findings, was that people are, which probably seems very obvious to a lot of parents, people are trying to find the balance of if childcare, the expense of it is worth doing it and worth maintaining going to work and using childcare, or if it's cheaper to just to take care of the kids themselves and not go to work. So it's the balance of financially, and also the limited availability. So people felt that there was a lack of availability of childcare, and when it was available, it was very expensive. Chronic disease. So you can see this goes, if you're a little bit confused, you can see that this goes back to a number 1 up here. That's because we've switched to the health outcomes. We are done with community conditions and we're going to health outcomes now. For chronic disease, the top issues and barriers actually weren't necessarily about the physical disease in the community, whether that's hypertension or heart disease. These are pretty on par with the state, so that's like a good reference point. But things that came up in focus groups, key informant interviews, and in general was the access to healthcare. So it wasn't necessarily that people thought that they had higher rates of disease or chronic disease. It was that if they did, or they were trying to manage a chronic disease, the concern was for the access and like getting access to your primary care physician. So you can see like the top issues is access to healthcare, management, just access, cost, and then also older adults came up too as people who are experiencing more barriers. Mental health. So this ended up being one of our priority health needs. And again, I'll say that youth mental health was something that came up a lot. So it was mentioned in every single focus group that we conducted. Youth mental health was mentioned at least once. So that was a thing that came up a lot. Also, when it comes to adults, you can see rates of, on the county level, of adults who are diagnosed with depression by a mental health professional. And also you can see the percentages of people who experience frequent mental distress. So this is something that a lot of people are struggling with, both adults and youth. Addiction and substance misuse. This also was a priority health need. So one of the priority health needs is behavioral health, which substance misuse and mental health will fall into. I'll talk briefly at the end about that, but as you can see on the left-hand side, unintentional drug overdose deaths and opioid overdose deaths were both higher than what we would like them to be. So the Healthy People 2030 national targets are significantly lower. So when we are looking at this is something that really stuck out. And when it comes to substance use for youth, vaping came up a lot. I'm sure that's not a surprise for a lot of people that among the youth, vaping was a huge problem that came across in a lot of the focus groups. Maternal, infant, and child health. The major finding for this was just the felt a lot of focus groups and key informant interviews felt that there wasn't enough access. So it kind of mirrors the access to healthcare, but particularly people mentioned a Brockton hospital that recently closed, or services that no longer exist anymore. And this is important because when you look at the on-time prenatal care for Plymouth and Norfolk County, it is lower than we would want it to be. So the target is 95%, and obviously you can see that they're significantly lower. So just like the general access came up, and the lack of access could contribute to like not getting care on time, or like on-time prenatal care is like at the beginning of your pregnancy. Tobacco and nicotine use, again, I'm sure this is not a surprise, but vaping came up again. So there was not many findings when it came to cigarette use, but vaping was a reoccurring theme, whether that's substance use or nicotine use, as a very big and important part of the focus groups and key informant interviews. Injuries, among the youth focus groups, fights in schools it came up a lot in the Abington and Brockton focus groups, just that when they were experiencing injuries, it was because of fights in schools. And then for adults, when it came to injuries, it was concern about car safety and traffic accidents in the community. For HIV and STIs, the overall finding with this was that people felt that there was a lack of education. So I'm sure that happens in many communities where people just feel that there could be more, whether that's for youth, adults, or older adults, just wanting the more education surrounding HIV and STIs. Okay, now that we've quickly gone over the findings, I'm about to wrap it up, but selecting the priority health needs. So remember at the beginning when I talked about how we go from the community health assessment to the community health improvement plan. So one of the parts of after reviewing the community health assessment, once we look at the data, we want to select those priority health needs. And this is when Moxley Public Health and the PN5 partners got together, and we went over the results of the community health assessment and talk through these criteria, the relevance, severity, impact, and obviously you can read the whole slide of all the criteria that we look at when we are defining those health needs. But one of the things that we really like to drive home when we are selecting those priority health needs is making sure you can actually address them. So like, do you have capacity? Do you have the resources, the money, the staff to address those health needs? So when we're going through this process, the last thing we want is to do all this work together, collect all this data, find exactly what we think needs to be addressed, and then try to address it and not having the resources. And so your community health improvement plan just sits there for a couple years. So that's the last thing that we want. So when we're having these conversations, the forefront of the conversation is it doable? Which is why when we choose strategies on the community health improvement plan, we would rather you choose one or two strategies that can be done and addressed effectively than choosing 7 or 8 different things that you want to put in the CHIP report. So when we're selecting these priorities, like I said, they were looked at from all these criteria, but also the capacity, availability, and resources. And lastly, so just to let you all know, the priority health needs have been selected for PM5, and they are access to healthcare, focusing on those social determinants of health, and then also behavioral health, focusing on mental health, addiction, substance use disorder, and adverse childhood experiences. And right now we are in the final stages of finalizing the community health improvement plan. So the strategies to address these health needs have been selected, and we're just in the final stages of completing that report. So we're really excited. We love working together with the PM5 team. And I know we're doing questions, I think, in a little bit. I don't know if we're doing like a panel setup, but if anyone has any questions, feel free to ask, and I'll turn it back over to Dr. Mondesir.
And now we're going to turn the podium to Dr. Sebastian, who is the Health and Human Services Commissioner for the City of Brockton.
Okay, before we go on to questions, we want to acknowledge the presence in our midst of highly respected colleagues from the DPH, particularly colleagues that have supported us in regards to this effort, the PM5 grant. We have in our presence please just a minute, I need to be sure I'm reading this right. We have in our presence Rachel Kane. Okay. She's the Deputy Director, Department of Public Health. Other than a show of hands, maybe you can also turn around and show your face. Thank you very much. We have also Lisa McCarthy. Lisa McCarthy. She's the Assistant Director for the Office of Local and Regional Health at the DPH also. Rachel is also from the Office of Regional and Local Health. Thank you very much for honoring us with your presence. We also have Bethany Grouse from the DPH. She's the program coordinator for the Office of the Local and Regional Health at the DPH. Thank you, Bethany, for coming. We also have in our midst the Assistant Commissioner of Health and Human Services for the entire county of Plymouth, Emily Wilson. Please, you may just greet the house and show your face. Thank you. Thank you.
Thank you, Dr. Sebastian. Good afternoon, and thank you for the opportunity to speak with all of you today. It is truly inspiring to be here with the Plymouth Norfolk 5 and the City of Brockton Health Department. And as we look at Plymouth Norfolk 5, a shared services arrangement that is not only embracing the future of local public health, but actively building it. Abington, Avon, Brockton, Stoughton, and Whitman should all be incredibly proud of the leadership, collaboration, and commitment you are demonstrating through this work. I have had the distinct pleasure and honor to work with this talented, dedicated group of local public health professionals for several years now, and I continue to be inspired by your ability to rise to the occasion and do unprecedented things in uncertain times to protect the health and well-being of everyone you serve. Now, as we know, Massachusetts has long been a national leader in public health, and thanks to your efforts, we are entering a new era of strength, coordination, and shared success. While our state's 351 local public health jurisdictions have historically faced challenges like limited staffing, inconsistent training opportunities, uneven data systems, today those challenges are being actively addressed, and much of this progress is happening through the Public Health Excellence Grant Program. The PHE grant is equipping communities with the tools and capacity to modernize public health, and the Plymouth Norfolk 5 SSA is an outstanding example of that progress in action. By signing an intermunicipal agreement and sharing staff across Abington, Avon, Brockton, Stoughton, and Whitman, you are demonstrating how collaboration can turn long-standing challenges into real, measurable improvements. For years, many local health departments have struggled to meet all components of the CDC's 10 essential public health services, not because of a lack of dedication, but because they lacked the resources and capacity needed to meet a myriad of demands. Today, with PHE grant support, communities like yours are preparing for and adopting the Foundational Public Health Services Framework, ensuring consistent, high-quality public health protection for residents across all 5 towns. This was once aspirational, and now it's achievable, and you're proving that every day. The success of the Plymouth Norfolk 5 highlights one of the greatest strengths of the PHE program, which is cross-jurisdictional sharing of services. No longer are Abington, Avon, Brockton, Stoughton, and Whitman working in isolation. You're pooling expertise, coordinating inspections, supporting shared specialists, and delivering services more efficiently and more effectively across all member communities. We have long known that shared models improve outcomes, staffing stability, and compliance with state and federal mandates. Now, because of your work, we are seeing those benefits become reality on the ground. Your progress is also strengthening one of the most essential pillars of present-day public health, data, just like this community health needs assessment we went over, which was incredible. Historically, inconsistent reporting systems have made it difficult to track trends or plan for future needs. But the PN5 is building the shared infrastructure needed for consistent, high-quality data collection, data that drives smarter decisions, strengthens performance, and supports a stronger response to emerging challenges. And with coordinated staffing and training, your workforce is becoming stronger, more connected, and better prepared than ever. The PHE grant is also helping to address long-standing funding inequities that have made it difficult for some Massachusetts towns to keep pace with public health mandates. By supporting shared services, the grant is ensuring that every dollar invested, whether in Abington, Avon, Brockton, Stoughton, or Whitman, goes further, reaches more people, and has a greater impact. This is what sustainable public health investment looks like. What we are witnessing through the PN5 is the beginning of a long-term transformation, and that transformation is being driven by your willingness to collaborate, innovate, and push towards higher standards. With ongoing engagement and partnership and continued support from the PHE program, we're building a stronger, more equitable public health system for every resident in your 5 communities. Most importantly, your work demonstrates a powerful truth. When municipalities join together, sharing staff, sharing ideas, and sharing responsibility, public health becomes not just stronger, but more sustainable for the future. This is progress we can see. This is progress we can measure, and this is progress you should be deeply proud of. Every resident in your 5 communities deserves a public health system capable of protecting them, and thanks to the members of the PN5, we're closer every day to making that vision a reality. Thank you for all that you're doing and for all that we will continue to accomplish together. Thank you.
Thank you very much, Bethany. We will make the floor open for questions now, but the questioning will dovetail into the first panel discussion. So, for this purpose, we want to recognize any persons representing any of the 5 communities. Perhaps we did not notice you when you came in. If you are representing Avon, can we have a show of hands? Abington, Whitman. We were all invited. I know we had quite some tight schedules and there were promises of presence, but let's also understand that some of these communities have a very small team, so sometimes it may just not be possible for that 1 or 2 people team to be able to make it today. But nevertheless, they are here with us in spirit because we planned this jointly. So if you have a question, please indicate by a show of hands. It may be a question, it may be a contribution, it may be a thought you want us to shed further light on. We have seated here Bethany and Dr. Eno, as well as Burke, the presenter. Between these 3 persons would tackle your questions or explore some of the things you think we should look further into concerning the presentations that she has just made. For example, starting off, I want to do an icebreaker. Before the PN5 study, the city of Brockton, we did our own study. In 2014, we rounded it up and concluded it in the first quarter of 2014. And I want to tell you that the 10 leading findings here that are priority were very similar with our own findings. They were very similar. And we did not share notes. They were not even aware that we had actually done a study. So these issues are real. When 2 studies are done by independent investigators, and you tend to find a common finding, it potentiates the strength of those findings. For those of us that have been in science for a while, this is one of the things you really look out for. If your findings can be repeated by another independent investigator, and I stand here to tell you, Burke, your findings were very similar to our findings within the city of Brockton. And these findings are now common across these 5 municipalities. So it behoves us, therefore, to take these issues beyond this level. And how do we take it further? what are the things as she has also mentioned, what are the things we need to do beyond getting a study done to getting the problems found tackled. So those are some of the things we want to throw some further light in through your contributions, through your questions, and through the deliberations. So please, if you have any thoughts to share or a question, please show us by a show of hands, and then you can have the mic.
Ask on my behalf, but when were
okay.
the key informant interviews conducted? When were the data pieces collected?
When were the key informant interviews conducted?
Yes, when was the
Beck, when were the key informant interviews conducted, and when was the data collected? The the KI interviews and the data collection, what period was it?
So those were mostly done over the past year. So at first we had like an influx of key informant interviews, and then they started to kind of trickle off a little bit. So, and especially since we did 49 of them, and each key informant interview takes about an hour. So it took us about over multiple months, almost a year, to do all the data collection when it came to the primary data collection. So over the past year, and then it ended. Our last key informant interview and focus group happened in the spring.
Every time I attend symposia like this and listen to reports like this, I get all excited about the data that has been collected. And at the end of the day, I ask myself one simple question. Now what? You've collected all this data, you've done all this incredible work. I was able to go in and see through the QR code and see everything you have, and I mean, I am enamored. This is going to be my reading for today. It's really exciting because that's the kind of data I've always thought about. What is available in our community? How do you even figure out this kind of information? You've done all the work. So what happens next? Because I don't want to sit here 2 years or 3 years or 5 years and hearing new reports about data received those years when, as we just heard a moment ago, something similar was done in 2014, and the problems are similar, the same with water and accessibility and all the other factors. Now what?
Something that we're also really passionate about, is kind of what I mentioned, is the community health improvement plan. So now that PN5 has done a complete community health assessment, and like I mentioned, we found those priority health needs, and now we're in the process of creating and finalizing the community health improvement plan. So PN5 has done such an amazing job on this plan. So it's a multi-year plan, and it addresses, so it has multiple strategies to address those priority health needs. So I believe it's a 2-year plan. And when we were creating those strategies and creating the community health improvement plan, we used these selection criteria. And so I think when you're talking about what can we actually do, what's actionable, hopefully this community health improvement plan fits within these criteria, and also the factor of capacity and resources. We feel like when we were working with PN5 to create this plan, the biggest thing that we talked about was, is it actually doable? Like, can you take this plan, look at it, like, are those steps actionable? And because the last thing we want is to do all this work, collect all this data, create this wonderful, beautiful community health improvement plan, and it just goes in a drawer and nobody looks at it and nobody does anything about it. But I think what's so unique about PN5, which is speaker, I'm sorry, I missed their name, who was speaking just prior to answering questions, the amount that they're working together around like 5 different towns or cities is something that I don't know if I've ever seen before. So hopefully that collaborative effort now that is so strong with PN5, combined with a strong community health improvement plan based off a solid community health assessment, my hope is that as PN5, as a partner, as a group, as a community, really getting that investment from the community, drawing them into the community health improvement plan, and honestly, this may sound corny, but everyone working together to actually complete these well-defined and actionable goals. So like I said, I know it might sound corny, but it really, I think something that can be so helpful when improving community health is just working together and getting the investment from, because everyone needs to be working together. Everyone knows someone who can help with this and help with this. So hopefully, I hope I answered your question that what do we do next is hopefully work together, look at that community health improvement plan and start working together to meet those goals.
Thank you very much, Beck. Yeah, you had her, and I wanted to add that at every level we can all work together. For me, for example, this will help me in advocacy that is backed with data, budgeting that is data informed. At my level, in my own niche, is I'm going to be informed in resource deployment, for example. But we are different niches. You can be involved in making a demand. You're members of this community from which this data has been obtained. Then you sit with your constituent. You sit with your constituent representatives and make a demand. You are making a demand, I'm making an advocacy. We're working at different ends. Together we can make things happen. We can bring about the change we desire. These are some of the things. So in various ways, we can all be involved. Yes.
I would just like to also add that part of the grant is development of a work plan, a yearly work plan. And I think this is a great opportunity to align these findings with that work plan that the group develops every fiscal year. For example, I know there was a slide about maternal and child health. That is a focus of the grant, and I think that's a great area where they could align in that work and develop goals and objectives that are time-bound, have to be met and are reported on throughout the year. And so it turns these kind of aspirational findings into actionable plans and measurable outcomes. And that's something that I have supported the group with and will continue to support them through the grant.
Let me say that among the things that I have learned from COVID-19 is the necessity to partner with other folks to do the job, because sometimes the work may seem unsurmountable for one person, for one department, but when we work all together, and it makes the load lighter. DPH has come forward. I know when DPH switched from providing direct services, case investigation at the end of 2022. Well, I think it's even December 2021. Every municipality was called to pick up the stub or pick up the work and move forward. But DPH did not just leave us there. It provided resources for each municipality to do the job. So the PN5, or the SSA, if you will, which is the Shared Services Agreement, for Brockton, Avon, Abington, Stoughton, and Whitman, it's a great game changer. Number one, it allows us to collaborate, which is not easy because each municipality has its own red tapes. I'll put it just blunt. But along with that, when we're able to sit around the table and consider that we have a population to serve, they're all Americans, they all live in our municipalities, they go to our churches. As Reverend Dr. Waya mentioned, he is a clergy in the city, so he serves people all over those towns. So when we work together, we address the issues. And so with the resources that DPH allocates to us, we will be able to do the job. There were some hurdles, but I can say those hurdles are behind us right now, and I'm seeing the light at the end of the tunnel.
I have two questions about the focus group. I would like to know how the people part of the focus group were selected. Was there any involvement from any, community group to select those people part of the focus group?
Thank you.
So for the focus groups, That was done a lot in conjunction with the PN5 partners. They help us like find people for key informant interviews. A lot of those came from introductions from PN5 partners. So for key informant interviews, they're representative of a population. So whether they're physicians, healthcare providers, counselors, social workers, community health workers. So honestly, the PN5 partners did a wonderful job connecting us with the community. So we are a virtual team. So I don't know if Dr. Mondesir, if you felt like there was, you all kind of led the charge on like getting those, creating those relationships with the community. And we ran some of the focus group. I know some of the PN5 partners ran the focus groups, but it was really like a team effort when it came to like getting into the community. I hope that answers your question.
Is any other question from anyone? Okay.
The community health improvement plan that Mostly is currently working on, is there any sort of timeline on when that is going to be ready? And secondly, is there any dissemination plans for that? Is that going to be made available to the public? Is that going to be made available to the public or, shared with community leaders? It would be really good to kind of get a sense for where this is going, what the direction is, and also whether Mostly would have any sort of, role in implementing and making changes, whether it's working with local communities or anything else. That'll be great to know.
Yeah. So one thing that I love about community health improvement plans is that they're always ongoing and they're always very flexible. So they can be, adapted through. So behind every community health
Can I
improvement
leave a
plan is
mic
actually
with
a
you
work plan that is
so that
constantly
if anyone
evolving
is
and
around here,
changing.
they'll be
So to answer your
encouraged
question, the
to,
community health improvement
because I
plan,
have a feeling
actually,
people
we
are
are in the
shy of
final
coming
stages of
out
it
all the
now.
way to
So
the
just
front,
doing those
but
tiny
they
little
indicate you
tweaks.
can just have them
So it'll be available to you all community health improvement plans and community health assessments are posted on all the local, so Whitman, Brockton, Avon, Abington's, and Stoughton's, their websites. So the community health improvement plans will all be posted there. The final one should be completely done, finalized, actually on Monday. But something that's really wonderful about the community health improvement plan is that everyone's welcome. If anyone from PM5 wants to, if you want to raise your hand, if you're a leader of a work group, but the community health improvement plan will have quarterly meetings, and based off whatever they will have reoccurring meetings to actually implement the community health improvement plan. So that's something where the PN5 leaders, you can bring in anyone that you feel like can be a valuable partner. Everyone is welcome to continue to do that work. So when I say that the document is always evolving, the final draft will be on Monday, but throughout it's a 2-year plan. So sometimes you run into barriers. Sometimes we've had a couple organizations that we worked with where their 2 or 3-year community health improvement plan was part of it, they didn't get funding for it anymore. So one of their federal grants didn't come through. So in that case, they had to completely shift their community health improvement plan. So, but for the next 2 years. So they have this beautiful plan that was supposed to be over 2 or 3 years. The funding gets cut, but luckily for a community health improvement plan, it can continue to adapt and mold over multiple years. So if you run into a barrier, adapt the strategy a little bit. But we would love, I know I'm speaking for the PM5 partners, but the more the merrier. So if you would like to get involved, I'm sure someone from PM5 would be more than happy to bring in those community partners, get involved in those work plan groups, and start to implement the CHIP together.
Hi. So after the community health improvement plan is provided and we are able to view it, what is the plan for monitoring or either program monitoring and evaluation to ensure that the things that are listed in that plan are actually being followed and implemented? So is there an evaluation plan that accompanies this improvement plan?
I think that question, and maybe Burke can come in with any additional information. Basically, the 5 municipalities will be working together moving forward. And so the grant itself is SSA, Shared Services Agreement, which means that we will continue to work together. Now, each municipality has its own resources outside what's provided through the grant. So what we can do what the grant allows, we will work together, we do it to try to accomplish, to address some of the needs addressed in the CHA. There may be other issues inherent to a specific municipality that may require other resources that is not readily available. And as you know, we live in an unprecedented time in politics because some of the resources probably at the end of June 2026 may not be available, or maybe the end of June 2027, FY27, they may not be there. But we will work together, whichever capacity we can, in order to address those common needs.
Doug, you wanted to make some remarks?
No, not, so Moxley Public Health, we work, I wish we could stay on for forever. So the end of our time working together is after the community health improvement plan is done. So we try to set everyone up for success, have those work plan groups scheduled, and create a plan of what the next 2 years could look like. So although I would love to stay and like monitor everything and like track how things are going, unfortunately I do not get to be involved with that, but I'm sure it'll be wonderful.
Thank you very much, Doug.
Of course.
I'd also like to add that through the grant and through the Office of Local and Regional Health, we do provide subject matter experts who shared services arrangements can request support through our office. And those are local public health professionals, usually retired folks who have worked in the field for many, many decades and have a wealth of experience that they can then bring to the groups to help them with marketing, with outreach, with planning and sustainability practices. So we don't just leave the shared services arrangements to fend for themselves once they have this information. And we really are trying to be responsive to what groups ask us for in the areas of expertise that our subject matter experts bring. And that is a service that we provide free of charge to our shared services arrangements, and hope that they will take advantage of it to move this work forward.
Just a quick comment, thank you. I just wanted to commend this work and also especially commend the innovative strategy on behalf of those community members that looked at adverse childhood experiences, and to really highlight that ACEs broadly, but how that impacts all of these other domains and areas that you're looking at. So just wanted to sort of hold that up. It is, incredibly innovative that you're looking at it as, both a framework and also a strategy to, carry forward best practices for youth development. So wanted to, to flag that and to express, excitement to see what comes next, especially with that. So thank you.
Well, thank you everyone for joining. It is not over. This is just about half. First of all, we want to say thank you to Bert for presenting these findings for us today. Moxley probably could not be in person, but I don't think we missed that much because we had a clear presentation. And so thank you, Bert, and thank you, Ms. Griles from DPH. And Dr. Sebastian for joining us for the first half. Now, hello everyone, sorry for the delay. We are now ready to start the second half of the symposium, and we are very fortunate to have DPH as a great supporter of the work among the 5 municipalities, and Brockton has been a great beneficiary. And today we have with us a significant presence from DPH. And the person that I'm about to introduce is from DPH as well. That's the Chief Public Health Nurse for the state of Massachusetts. And she is Caitlin Biedengill. And please welcome her. She's going to continue with the second half of the program for us. Please give her a warm welcome.
Hello everyone, I'm Caitlin Pettengill. I support the public health nurses across the state. They're your invisible shield. They're doing all the things you don't know that they're doing to keep everyone healthy and safe. I want to give a special shout out right now to Jessica who's here. Jessica, where are you? Jessica, please. This is your Brockton public health nurse. She is supporting some of the most vulnerable residents, doing things you don't know she's doing, and that's the beauty and problem with public health, is that when we do a really good job, you don't know that we're doing it. The two public health nurses, Jessica and her colleague Lynn, are some of the hardest working, most amazing public health nurses in this state. I don't work Fridays. I don't work Fridays, but when Lynn or Jessica asked me to be here on a Friday, then I'm going to be here on a Friday because I'm going to show up for these things. I am really honored to be introducing these 3 doctors that are really making a difference in Massachusetts and here in the city of Brockton and in this regional area. The first doctor I want to introduce is my colleague, Dr. Zeidman. She serves as the Deputy Commissioner and Chief Medical Officer for the Massachusetts Department of Public Health. In this role, she provides strategic leadership for the department's work with healthcare system and coordinates clinical resources across DPH and across the state. She also oversees the Bureau of Healthcare Safety and Quality and the Bureau of Healthcare Professional Licensures, the Board of Registration of Medicine, and the Office of Healthcare Strategy and Planning. Wow. These bureaus and offices regulate health professional and facility licensure while providing support to key state initiatives to address emerging public health challenges. I can tell you that Dr. Zeidman just is a wonderful colleague and a huge champion of healthcare in Massachusetts, so I'm just honored to be introducing her today. Next, I want to introduce Dr. Celestin. Where's Dr. Celestin? He is the adjunct professor of counseling at the Gordon Conwell Theoretical Seminary. He's also the director of Building Alliance to support immigrant mental health. And in addition, he is the administrator of Sentinel Ministries. Also joining us today is Dr. Lawson. He is the Chief Medical Officer for the Boston Medical Center South. He's worked in the Brockton area for over 20 years. He's trained in emergency medicine at Boston City Hospital. Having worked as an emergency attending at various Massachusetts hospitals, an intern chief of emergency medicine at South Shore Hospital, chief of emergency medicine at Signature Brockton Hospital, chief medical officer at St. Anne's Hospital, and chief medical officer at New England Sinai Hospital. I have one more person I'm going to introduce, and then Dr. Lawson and that next person are going to give you some updates about their facilities before we start the panel. First, it's Dr. Maria Celli is the Chief Executive Officer and psychologist who serves at the Brockton Neighborhood Health Center CEO. Maria graduated from Tufts with a bachelor's degree in international relations and Spanish. She received her doctorate in psychology from William James College, and she joins us today. I'm going to have them both come up here.
Thank you for having me. Thank you to the Brockton Health Department for hosting this symposium, and to the regional shared service partners in Plymouth and Norfolk counties, the towns of Abington, Avon, Brockton, Stoughton, and Whitman. I am so incredibly grateful to be a part, oh thank you, people maybe can't quite hear me. I am so grateful to be a part of this conversation today at this really, truly critical moment in public health. It's a moment that demands clarity, collaboration, and resolve. It's a moment that is both important and urgent. Today you're sharing community health needs assessment data that reflect real experiences and the real lives of people in this region, where they thrive, where they struggle, and where our systems fall short all too often. These data tell a story about gaps, barriers, but they also tell a story about opportunities. And I know that that's where the attention is shifting with the community health improvement plans. But they're really telling a story about people. And they tell a story about strengths. They tell a story about committed local leaders. That's what I saw when I read that report a couple of weeks ago. Engaged residents and innovative public health work that is already underway here in these communities in collaboration with healthcare providers. The data that you're sharing today and that you're discussing today really reaffirms a fundamental truth in public health, that health outcomes are shaped far more by the conditions in which people live than they are by the care they receive when they get sick. I mean, sure, medical care matters. I'm a primary care doctor, so of course I have to believe that and say that, or I wouldn't be doing what I'm doing in the clinic. That is, if it's accessible. But it really only accounts for a fraction of health outcomes. The rest is determined by all the other things that we're talking about today, in addition to healthcare access, housing stability, food access, education, transportation, environmental exposures, income, and fundamentally the safety and the cohesiveness of the communities in which we are all living our lives. These are the social determinants of health. And when the conditions are strong, health can thrive. And when they are fragile, illness often follows. And of course, because these social determinants of health are not distributed equally in society, health outcomes are also not distributed equally. The disparities that we see in chronic disease, mental health, maternal health, and life expectancy are not random. They reflect structural inequities that are built, that we built as a society, and that have persisted for generations. And the community health improvement plans that you will all be shifting your attention to are efforts to interrupt that built system and to rebuild it in a new way, as you all have been doing in this area for a long, long time. The inequities that we see are the result of systems that have not treated all communities fairly or justly. And addressing these inequities requires the kind of collaborative cross-sector partnership that I see in this entire room. We have to recognize these troubling injustices that are inherent in our society. We have to call them out, study them, and address them head on. That's what the community health needs assessment enables us to do. Equity cannot be a side issue in public health. It cannot become a piece of the conversation that is rendered silent or implied. Equity is the work of public health, and it always has been. The most urgent challenge that's reflected in the community health needs assessment, and it's one that really kind of strikes close to my heart and is felt really deeply in this region, is access to care. Not surprising, right? And this area is not unique in Massachusetts, and it's not unique in the country, and identifying that as a key public health challenge. Getting healthcare today is complicated, it's incredibly frustrating, and it is super confusing. Massachusetts, like virtually every other state, is grappling with really significant shortages of primary care and psychiatrists, and we have a struggling workforce, long waits for new patient appointments, and pressures that are pushing providers out of practice. I'll tell a story from my own primary care practice in Chelsea, Mass. In a span of about 18 months, we lost about 4 providers, doctors and nurse practitioners. They cared for a quarter of our patients. For several years, as we tried to rebuild that gap and fill that gap, we had about 5,000 people who lost their primary care doctor. 5,000 people. In a study of 15 major US metropolitan areas, Boston ranked second, the greater Boston area ranked second for the longest wait time for routine physical. These are the challenges that are reflected in your community health needs assessment when the community identifies access to care as its #1 issue. But they're just a piece of that access challenge and access. Our system is clearly under strain, and we understand that finding care is a struggle for people and families every single day. I see this, I live this, and of course I feel it in my own practice as a primary care doctor in Chelsea. For getting my patients the care they need is hard every single day. And really importantly, and why we're here today having this conversation, is that this is not just a conversation about healthcare. Access is not just about having appointments that are available. It's also about getting there, getting off of work, and not having to choose between paying for your medication and paying for the roof over your head or the food in your refrigerator. At the Massachusetts Department of Public Health, we're working to respond to these issues, as you all are as well. We've created, from a healthcare workforce perspective, we've created licensure pathways for primary care physicians and psychiatrists. And we partner with the Mass League of Community Health Centers, a fabulous partner, to offer loan repayment and incentive programs to specifically recruit clinicians of all discipline types into primary care and behavioral health needs. And these efforts really do matter. We need that workforce. We can't solve this problem without them, but they're only part of the longer-term solution. Here in this region, hospital closures have also intensified the problem of healthcare access. When a hospital closes, communities don't just lose beds, right? They lose these trusted and long-standing entry points to care, specialty referrals, and also local jobs, getting to some of the employment challenges that were raised in the community health needs assessment. And the effects of hospital closure ripple outwards. They increase travel times, crowd remaining healthcare facilities, both hospitals and outpatient. And they create significant barriers for those with limited transportation in particular, which we know is a challenge in this particular region given limited public transit. It also creates, audio problem, all right. I'll lean in, might be a little awkward for the folks in the room. Thank you. Okay, great. I'll listen for the echo in my voice. Better? Okay. Creates problems not just for folks who have particular transportation needs, but also folks with inflexible work schedules or complex health needs. Beyond physician shortages and closed hospitals, we also see the impact of pharmacy closures on many communities in the state, including this one. Losing a neighborhood pharmacy reduces the obvious things, right? Access to medications. But it also impacts access to vaccines, and it impacts access to just sort of everyday health guidance. Where should I use my Tylenol for? How much Tylenol can I take? Community pharmacists are a really important part of people getting the health guidance that they need every day. Pharmacies are often some of the most accessible healthcare sites in a community, and so when we lose them, that gap is felt immediately. The data from the Community Health Needs Assessment also point to important trends in maternal and infant health. While the preterm birth rates and infant mortality rates in Plymouth and Norfolk counties remain relatively low, which is wonderful, and a thing to celebrate. Pregnant people in this region, as was covered earlier, are also more likely to experience delays in getting prenatal care. And that matters, of course, we know because early, consistent prenatal care is one of the strongest predictors of healthy births, healthy parents, and long-term child health. These delays in prenatal care access may be caused by clinic capacity and provider availability, and of course, I can't say that that's not a factor, it is a factor. But they're also driven or aggravated by this other social determinants of health that we're talking about today. Transportation, insurance barriers, affordability that's connected to that, language access, and increasingly, unfortunately, for folks who are living in our communities who are born outside of the United States, fear. It's not enough for these appointments to exist. People have to be able to get to them. These are, for the most part, solvable problems, but they will only be solved if we address them and see them as urgent. The Community Health Needs Assessment, of course, also underscores the impact of a range of social determinants of health on the health of communities in this region. Food insecurity, economic stability, housing, and environmental conditions, as well as transportation. I focus so far on the issues that present challenges to the health, safety, and well-being of our communities. But it's equally important to highlight what is working, and I want to take this opportunity to really celebrate a recent initiative that is just so fabulous. I love it. It's one of these initiatives that makes all of us working in public health and protecting the folks that we live around incredibly happy. And that is the Brockton Vaccination Initiative in public schools. So Brockton recently launched the vaccination initiative in partnership with Brockton Public Schools to provide childhood vaccines directly to students who aren't up to date with them. This program, which represents nearly a year of planning and collaboration, held its first clinic just a few weeks ago. And this initiative matters because hundreds of school children in Brockton had been identified as not being up to date with their vaccinations. And that troubling statistic, the data that drives action, that troubling statistic became a call to action. By bringing vaccines directly into schools, Brockton is reducing or even eliminating many of the barriers to vaccination. The things we keep talking about: transportation, time off of work, cost, and access. Brockton is meeting families where they are. And that is what modern public health, community-centered practice looks like in action. This initiative is a model of what it means to move from data to action, to move from the kind of data that we were talking about in the first half of our afternoon session today to the planning process that will be shared with you early next week. Oh my gosh, that's amazing. I have a soundtrack. And all right, fantastic. And as many of you know, right now, towns in South Carolina are currently straining to contain a measles outbreak that has affected hundreds of people. It has sickened over 100 people, and there are over 250 that have been quarantined, that are missing school, that are missing work, for whom it's impacting their ability to care for the other loved ones that they have in their lives. The tinder for that outbreak, as it has been in many other states, was schools with vaccination rates lower than the 95% threshold required to keep communities safe from measles. Schools were the spark that caught fire that fueled the outbreak in South Carolina, as they have been in other places. And the initiative that you all have embarked on here locally says not here, never here. Not here, never here. As everyone in this room knows, we're doing this work at a time when public health is under extraordinary pressure, even under attack, some might say. Across the country, we're seeing decisions that appear to be totally divorced, completely divorced from evidence, from science, from data, from prevention, and from long-term impact or any consideration of what the consequences will be on communities. We're seeing increased misinformation coming from federal sources that had until recently been considered the gold standard for sound public health advice. And perhaps most concerning, and this is not unique to this federal administration, this has been going on for a while, we're seeing an overall erosion in trust in science, public health, and even healthcare providers. I also recognize that many of you in this room work directly in public health, and I want to say emphatically that your work matters. Matters a lot, matters a ton. I get energy from being in this room with you all. Every clinic you support, every screening you run, every child you vaccinate, and every barrier that you individually and you collectively lower changes the trajectory of someone's life. I'm saying the obvious, but I think especially right now, we kind of can't say it to each other enough. Here in Massachusetts, we will continue to be guided by the science, grounded in equity, and committed to protecting access to care. We will support your communities as you innovate, lead, and continue to act. And I promise you that the Massachusetts Department of Public Health remains committed to health equity. It's not optional, it's not negotiable, it is deeply baked in to the core science of public health. Equity is the work of public health. The gaps and the barriers that we're all talking about today are real, but they represent only one chapter of the larger story. The full unabridged version of this region's narrative is also about its people, its strengths, its partnerships, and its possibilities, and how to keep moving down that pathway towards progress, as we're talking about today and holding each other accountable for. Towards this goal of building something that is stronger, better, and more fair and equitable. The community health assessment provides a roadmap, but the partnerships, among the stakeholders in this room provide the foundation, and the commitment of the rest of everybody in this room and the others who care deeply about your communities provide the strength to take this journey, which will not always be an easy journey, and I know has not always been to date. Thank you for the work that you do every day and for your absolutely unshakable commitment to the health of these communities, your towns, this region, and to our Commonwealth. And thank you so much for letting me be a part of this conversation today.
Joining us on the panel will also be Reverend Dr. Abraham Laya, who is the clergy at the Central United Methodist Church and faculty at Boston University. Is there anything that the panel would like to add to anything that's been stated?
Hi, everybody. My name is Maria Celli. I am the CEO of Brockton Neighborhood Health Center. I'm very proud to represent BNHC today. I've been at Brockton Neighborhood for almost 10 years, but I've just assumed the role of CEO in the last 7 months. And I did have a presentation to present, but that's not what I was about to say. Because I wasn't sure if we were going to go there in the interest of time. So now I've cut you in line, Dr. Lawson. I'll do it super fast. I'm representing Brockton Neighborhood Health Center, and we are the one of the largest community health centers in Massachusetts. We serve almost 40,000 patients. We're the only community health center in Brockton, and we serve, all of the municipalities that are part of this PN5. Okay. This is a little bit about us, our mission statement. The more important thing is to see us in the photograph, which is that we are a health center with a lot of hard work that we do, but also a lot of joy and love that we bring to our work and commitment. The values that we stand by are here. I'm not going to name them. I will highlight that we were incorporated in 1992 and we started in a van in a parking lot, part-time, like I don't remember, but about 8 hours a week. And we have grown to 5 clinical sites, I think a total of 7 sites. And as I said, almost 40,000 patients, over 215,000 visits a year, and a staff of almost 600 individuals. These are our clinical locations. Our main site, otherwise known as the Mothership, at 63 Main Street. Our Pleasant Street location, which is pediatrics. Manley Street location is our clinic within a homeless shelter with a partnership with Father Builds in Mainspring. A mobile unit that is primarily serving those who live on the street or are struggling with homelessness, and a small developing school-based health center. And I do want to point out that this is what I was going to come up to say if I didn't present, is that while there is, we certainly feel, and I think the public health, the Board of Health feels it, and the healthcare industry is feeling it, a lot of pressures that have been named around access, soon to be around health insurance coverage and access to Medicaid in the context of the big beautiful bill. Commentary to the side.
Yes.
But I will say that, we are so committed to trying to create access that we do currently have access for primary care. So to all of the agencies that are in the community, we currently have access to primary care. And we as the team feel committed, but I and Maria Celli feel very committed to trying to serve as many people in the community as possible. When we speak about primary care, we're talking about primary medical care, but also access to community health workers, access to behavioral health as an integrated and essential part of your primary care. And I say that because we also saw in our own population the concerns around youth mental health. It's, I feel affirmed when I see it in the CHA, the community health assessment, but we saw it in our own patients, and we invested in programming for youth mental health within the clinic and at the school and at the high school. We heard when we heard about the vaccination gap at the high school and are trying to build out a sustainable medical program, primary care program for the high school as well. We saw the need around maternal health access, and we have applied for grant funding and have numerous grant programs and initiatives that are running within our OBGYN department to provide equitable access to maternal health care, and as well as the data to help us to evaluate our own progress. So we want to be a part of the larger ecosystem collaborations, even with the other municipalities, to move that work plan forward. I think Dr. Montesir knows that. Just whizzing by here, I won't get into all of this because, but you can see, over 60% of our patients are from Brockton, over 70% of our patients are covered by Medicaid or are underinsured and covered by the health safety net. So this is an area of great concern for us coming up, as some people may lose Medicaid eligibility, and BNHC is getting ready for that, but I think that is a major threat that was not reflected in the CHA, because at the time that the key informant interviews were being taken, that wasn't such a threat that we would know would be coming. I think we should be ready for that as a community. And I know BNHC is doing it, and I know separate agencies are doing it, but I think we should come together and address it the way we did COVID, in a way. Something about our patient demographics, I do want to just point out, as I said, some of our core services, primary care services, OBGYN, endocrinology, neuropsychiatry, and some remote cardiology consultation. Substance use services is part of our core services, behavioral health, dental, infectious diseases, eye services, a thriving pharmacy, and nutrition services. So some of you know us really well, but if you haven't seen BNHC ever before or would be interested in coming by to visit, please see me at the end or see the amazing BNHC team at the back. And you can stop by and pay a visit and get to know us. We have a lot of services and we're really proud about them. Another need that had arisen in the CHA and that we had seen in our own workforce and in the community was need for future primary care providers. Who are the Dr. Zeidmans of the future? Who are the Dr. Lawsons of the future, and the Maria Cellis and all of the staff at the health center? And so we started to invest in workforce development within our own staff, and then we built those pathways out even into high schools in the region. So we have a program, thanks to the generous funding of the HRS Health Equity Foundation. We built a program with the Brockton High School called the Hometown Healthcare Academy. I don't know if anybody's here from HHA, but it's an excellent program. Marlene Amidy's here from Haitian Community Partners, who we partner with. And Moises Rodriguez, representing still the Cape Verdean Association. Okay. So we work with the Cape Verdean Association, the Brockton High School, and we're trying to develop future healthcare providers from the high school. And that can work at BNHC, that could work at the local hospitals. But we are really trying to invest in workforce development through partnerships and even within our own staff. So I guess I want to say that there has been, and I mean, these are some of the system challenges that we've been dealing with, COVID, all sorts of disruptions, but I think even with all of that stress, there is hope, and I think some of that hope comes in the collaboration that I know is possible in the city. I've seen it, I've worked it, and BNHC is here to do it again. Dr. Lawson, do you want to come up?
Sure. So why don't we get started while the slides come up, because I'll screw them up anyway as we go. I'm Ken Lawson, I'm the Chief Medical Officer at Boston Medical Center South, and excellent. Put something down. Oh, this is awesome. Yeah, I will not belabor the slides too much, but I thought it would be time to reintroduce the hospital. Our hospital's been through a rather chaotic 5 or 6 years, and I thought I'd bring that here because we are one of your partners. In the overall scope of healthcare, being a hospital, we're probably a very small partner, but I think a critical access need in the community. And listening to everyone here today, it makes me reflect on just how close and how fragile our healthcare system is. Even in Massachusetts, even with, we've got some of the best hospitals in the world around us, but it's still, it's a narrow margin that we ride along in. So, who are we? So we're passionate community-centered care. We are a fairly good size, fairly large community hospital, and we want to stay exactly that. We're not trying to become a tertiary center. We just want to provide the best care in the community, keeping patients in the community that are appropriate as we go forward. We're chronic disease, heart disease, obesity, diabetes, etc. We have a very robust emergency department. With that, we're a level 3 trauma center, we're a cardiac care center, we're a stroke center. We do delivery, we have a level 2 nursery. All of these things have been running for quite a while under the name of Good Samaritan Medical Center under Stewart Healthcare, which is usually followed by a chorus of boos or something like that. Well deserved, don't quote me. But we've come out from all that. Right now, even through the tough years that we've had, the service that's been given by the team there, the staff there, has been really exemplary. Of all of these things, there are current awards and recognitions. I really like the Patient Safety Excellence Award. It's the top 5% in the country, and it's purely measurable metrics going out. So it's a nice thing to have for that. But I think it's credit to the team that works there. And I'm hoping that it gives people a sense of a little bit of confidence and trust when your patients come into us as we move forward. A little bit of the timeline of the hospital, and I'm not going to go through all this, but just for fun, I happened to notice that back in 1959, you could build an entire hospital for $1.4 million. Right now, it's about 80 times that to build a hospital, which may be why there's not a lot of hospitals going in right now. But if we fast forward on this, you'll see under Stewart, okay, I didn't do that. All right. So if you look at the last few years, so I was an emergency medicine chief of a fairly good sized emergency department in Brockton, and shifted over just in time for all the fun to happen here. So I came into a brand new emergency department that Dr. Herman put in, thankfully, for that. But moved over to Good Samaritan Hospital right after it achieved its trauma center designation. It's the first trauma center in all of Region 5. A huge chunk of Massachusetts and desperately needed for services. But as we go forward, it's showing how tenuous healthcare is. So less than a year into it, we have COVID. And everyone has tales of COVID, but just for our community here, we got our first COVID case. 2 weeks later, we had 236 inpatients with COVID, 40 intubated patients, and 75 deaths in our community. It was hit very hard, very fast. Some of the unique reasons why are all the things we've spoken about with that. But that took every single bed and 40 extra beds for the entire hospital. So what do you do with your heart attacks and strokes and everything else that goes on? So we're merrily going along, and we all get through COVID, through a lot of resilience, etc. In July, Norwood Hospital closed. They had a water main break. I remember getting the call, because I was the administrator on call for the region, and they said they had a leak. And like the next statement was, there's divers in the basement trying to find the source. So the entire hospital shut down in hours. A credit to everyone in the region. They got everyone out. Everyone was safe. No one was killed in the event. So now we have one acute care hospital taken offline, and with that, 61 behavioral health beds. We do not have enough behavioral health beds in Massachusetts. We know that. As we go forward, We're in part of Stewart. Stewart's gradually heading into bankruptcy during this time period, and we get into this period where Brockton has a fire. So another hospital closes within hours. They're able to evacuate the hospital, and the credit to everyone in this entire region that no one was killed. Huge with that. But we all talked about the day when all patients were moved out of the hospital. To me, being in the business, that's the smallest part of that emergency. It was the next 18 months when we did not have enough beds in the region. And every single day, the surrounding hospitals were in a state of emergency. So that was Brockton Hospital. We were still Good Sam at that time. And then later in the year, in June, Compass Medical closes. So now we're starting to talk about, we've got a financial thing with Stewart, which is a whole wonderful discussion. It could be a lecture series on private equity and money and greed. And who knows? Again, don't quote me. And then we get to Compass Medical closing overnight, and all these patients need to have access. So another stress on the system, and we don't have excess capacity here. We get to May of 24, Stewart Healthcare declares bankruptcy. Talk about a damage to trust in the healthcare system. And the state is faced with all of these hospitals that potentially could go under. Are they going to be sold? Do they need to be closed? A lot of major decisions have to be made. And very quickly during that time period, a lot of credit to the state for helping in this process in Boston Medical Center. But that was sort of the bottom of all of these things going on. We were acquired by Boston Medical Center, which I think was a fantastic match. And since then, we've been going vertical. We've been strengthening the system in the region since then. So big credit for that. As we go forward now, we are Boston Medical Center South. Good Sam is gone, Stewart is gone. With that, and we're sticking with that. There's Boston Medical Center, we call it Maine. There's Boston Medical Center Brighton, which used to be St. Elizabeth's, and our hospital, Boston Medical Center South. So, continued dedication, we are going to continue to grow with that. What's nice for this is Boston Medical Center is a large healthcare entity and now healthcare system. And they have all these other things which I don't think anyone in our area knew everything that's on this list. You sort of know some of them. But just looking up there, you can see the medical center being formed. It used to be City Hospital, my alma mater. With that, forming with Boston University Medical School, the medical group. For there, they have 700 plus attendings in the medical group. To give you an idea, our medical staff is about 700 as well at Boston Medical Center South. Moving down, so you've got the healthcare networks, they've got the facilities that they cover. WellSense is something also run by the health system. It has 700,000 covered lives in it, so pretty impressive. BACO, and you keep going down the line, a pharmacy network. And then the most important thing is that they acquired Good Samaritan Medical Center and became South with that. So I like the exceptional care without exception. That's a nice thing. It means a lot. Respect powered by empathy, moving mountains, and what a wonderful statement. Many faces create our greatness. Okay, and I think that's real. I think it's a really good match of Boston Medical Center and Good Sam to make Boston Medical Center South. I mean, you can't go wrong with that. I think we have very, very much aligned interests as we go forward. Health equity framework. So what are we doing? As we move forward, the highlight here is access to care and equity, enhanced care for more patients, rebuilding primary care, enhancing access to specialty services, all the things that we need, all the things that we've been speaking about. There's a very concerted interest in growing here. Under the prior owner, the hospital was unable to grow because no money was being reinvested in it when it desperately needed to be reinvested. So, little things like we have a 3D tomo for mammography. If you look back on our slides, that is a critical access right now. We do not have enough mammogram capabilities in the region. Adding machines for that. We just added 11 radiologists to read mammograms. Huge. We're trying to catch up because we're years behind in the region with that. As we continue to grow with this, we have just implemented EPIC. EPIC is a healthcare record system which is immensely complicated. It's very intricate. It's in everything, but it allows us access to records all over the country, and right now, pretty much all over the world. So it's better healthcare for your patients. Think about it, in today's world, it's a $100 million investment in healthcare for the 2 hospitals to be added to Boston Medical Center system. So there's really a lot being put for our growth going forward, things that we need. So I think these are really positive things. And again, I'm hoping people stop using the term good Sam. It's hard a little bit. But we want this to be Boston Medical Center South, and understanding that we take very seriously that we are a partner as we move forward. And we're hoping to really align everything with Boston Medical Center. We work well with the state. We can't thank them enough. We wouldn't be here in this capacity if the state hadn't intervened for that. So please spread the word with that. But we have a bright future together, and we desperately need to keep places like this going and growing with that. Luckily, Brockton Hospital reopened. We need 2 hospitals in this region. We don't have enough inpatient beds to handle the volume with that. One of the things I forgot to mention on that, just thinking of expansion and doing the right thing, Boston Medical Center opened up a behavioral health hospital here in Brockton, 106 beds. That's huge. We are all part of that. I think you've got a lot of people sort of leaning in at the right time. Everyone's for the same purpose as we go forward, and just wanted to reintroduce our hospital. That's it.
Thank you, Dr. Lawson. Dr. Wyatt, do you have anything that you want to come up and say?
Thank you, Dr. Lawson. I'm still struggling to come to when somebody says to me, oh, the patient is at Cardinal Cushing.
Yeah, exactly.
But where is that? I don't know about that. So I think we're still going to say good sound for a while, but we'll learn it, and someday we'll forget what that meant. I'm going to keep this very brief because I think that there is a significant role that faith communities play in public health. We can go all the way back to scripture and consider what the book of Leviticus says about how to treat people with all kinds of diseases and how to quarantine and how many days to inspect. And if you see this sign or the other sign, this is what you're supposed to do. And it's all written. If you have the leisure to do that scientifically, spend time and read Leviticus chapter 13. It gives you a laid out plan. So when faith communities are ignorant, which happens sometimes, especially during the pandemic, we end up struggling to help people to understand that when we are asking people not to come to church, which they think is a do or die issue, that there is a biblical reason why we need to show love for our neighbors by making sure that we ourselves are very well. I think that we learned a lot during the COVID period in this community. Dr. Mondesir really championed a team of getting people who are religious communities in the religious leaders in the community to partner together, to work together. One of the reasons why sometimes we miss out on the benefits of faith communities is that there are many things, and you may find it surprising, that people will not tell their health professionals until they have arrived by their clergy. Because they are not sure what are the biases, what are the things that might happen. Is it even a health issue or is it actually a spiritual issue, especially when it comes to mental health? So if somebody's having a problem with their children and they don't, you say, you take it, oh no, it's going to be on their record, and for the rest of their life they're going to be labeled this, so I'm not going to take them to the hospital. I just want you to come and pray over them, and then things will be okay. And don't get me wrong, I believe in the power of prayer, but I also believe in the power of medical science. That you can encourage people because they have trust in you. You can say, let's go do this. I will walk with you. I will come with you to the mental health professional. I assure you it's all going to be okay. That gives them a little relief to say, well, I ran it by my clergy and they said it's good, so I'm going to go for it. Or some of the stigmas that goes with sexually transmitted diseases and how people assume it's because they have done something wrong, that God is punishing them, and therefore they don't want to go and tell somebody else. Not only is it about the disease, but also about the moral situation they feel. So you have to talk with them and convince them that God is a bigger picture, and I'm not sure that that one that you're worried about is God's concern with you right now. If you're not alive, you're useless to anybody. So there is a relationship of trust that I believe contributes to enabling people to actually take that step. I can't tell you how many times I have walked with somebody to a medical appointment because they were uncomfortable going by themselves. Or how many times I've held somebody's hand and prayed with them as they were rolled in for surgery because they felt it was something that would actually transform their lives and make it maybe more acceptable. It's interesting that I'm sitting here, I have two people in hospital, I'm texting them to see how they are doing because they need to know that their clergy person is with them. And they need to know there's a whole faith community that's watching over them. So they feel comfortable going in to the hospitals to say, I have this certain needs, some of which, if not addressed, may actually impact their neighbors and other people. Let me say one other thing. Those of us who are in spiritual leadership find it necessary to model for the people at the church certain behaviors. And we are not good at doing it, truth be told. During COVID, I know I preached a lot about people, the needs to go and get your vaccines. I preached a lot about, I actually found sermons from 1918, 1919 about the Spanish flu to kind of make the case for it. And then I remember one day sitting with people and they are older and more vulnerable. So, why have you gotten your vaccine? Not yet, or what? And somebody said to me, Pastor, have you gotten your vaccine? And I said, well, not yet. It's like, oh. I called Dr. Mondesir, we arranged, and the church became a vaccination spot. So we got people to come in. People who were scared, people who had been told that the vaccine was not something to believe in and that it was going to cause God knows what. And their pastor has told them about it, but I was first in line so they could see that as a model, that I believe in vaccination. I'm from Africa. No vaccine, no life. I can tell you this. I hear all these arguments about vaccine, and like, I'm standing alive today because of many of the vaccinations that I got when I was a child. And so I felt comfortable doing that, but we have to be models, not just telling people what to do, but actually being at the forefront. And so it was easy when I went for my booster and everything. It was a lot easier to convince people the second time around because they already did. And one last thing, churches and religious communities have facilities that are useful. I just mentioned the vaccination workshop. The church has a space. So we can create that atmosphere, encourage people to come over and participate, because you don't have to go rent space somewhere else or find a location somewhere else, but we can do that at that space. So I think partially it has worked in my relationship with Dr. Mondesir because I know people. I don't know if it's somebody else, how that might have worked out, but certainly personal interaction. This kind of events, I'm here with a fractured foot, but somebody said that if they are partners, but you're the one who said you're usually not working on Fridays? Right. All right. Right. I mean, if Dr. Mondesir calls, I show up, right? Because I believe in what we do together. During COVID, it was a challenging time where we developed a spirit of we are in this together. It's not just the mental health or the physical health, it's a collaborative effort. I remember Dr. Herman, we just talked a few minutes ago. We were on the line every week, all the data, all the information. clergy were bringing, what is the problem in my church? What can you update us? And then we share it. So there's a commonality of understanding. And I would say that our public health will not be successful if we do not partner with each other. Thank you.
Thank you. I'm going to read Leviticus chapter 13 tonight. Dr. Celestin, do you want to come up and give some remarks?
Well, I prepared a reading statement to present to you for my time, but I realize if I do, I will be preaching to the choir. I had a chance to go around the tables here. I saw that all the things that I prepared to convince you about, they're all represented in different tables here. So let me begin by saying first who I am. I am a husband of one wife for 34 years, and I have 2 children, well, 2 born one. One is married, the other one is still available and miserable. So if you are interested, please let me know. He's not even for sale. We will give him up. Why is this important? It's because perhaps you ask the question, who's taking care of the caretaker? Because the rest of us, that's what we do. We take care of people. There is what we do and there is who we are as well. I am a pastor. My church is in Boston. I am the assistant pastor at Tabernacle Baptist Congregation. And it's one of the largest Haitian church in the community. But also we have this challenge that comes to us every day. And it started becoming even harder with the political climate that we are dealing with today. I work at EC, that's Immigrant Family Services Institute. I am the director of something called Building Alliance to Support Immigrant Mental Health. This, a long time ago, when I started teaching at Gordon Conwell Theological Seminary, I started back in 2004, but in 2008, I was responsible for the counseling department at CUNE in Bowen Street in Roxbury. We were using DSM-3, DSM-4. At that time, when we diagnosed someone, typically we don't know exactly what is the most fit diagnosis. We go with NOS, not otherwise specified. So when the DSM-5 comes around, they eliminate that. But as we speak today, it seems to be a new category that needs to be added because in your community, you have what is known as immigrant mental health. And that is going to be a very serious thing. Because these days, you diagnose somebody with something, then you find out that's not it. The client tells you it's not the problem. When you thought it was this, you talk about adjustment disorder. It's not that. You talk about this type of problem. This young kid comes to you and tell you that he has this and that. You think he's been abused or she's been abused, neglected and everything. And you find out, that's not it. So the question is, what is it? It's immigrant mental health. It's a different view, it's a different thing that a group of people come in the community and they come with themselves. They are cultured people and they bring their culture with them. And of course, everything that we are affected with in society, they've been affected with all of them. And then also they happen to be displaced people. And in the process of being displaced, moving from one place to another, they carry all this burden with them. Sometimes they go with trauma. They realize, no, it's not really trauma. Then the question again goes back where it is. Sometimes the rest of us, we feel like we are incompetent because we don't really know what we are dealing with. Because the problem that the immigrant mental health is going to bring to the community is yet to be diagnosed and be considered. The schools, we realize many diagnoses that are coming to us. Children with 2, 3 years old, they come with a diagnosis, autism, diagnosis with ADHD, 3 years old, diagnosis with social disorder. This kid doesn't know and respect other people's right because he's only 2 and he says no and he can spell it for you. And you understand that there is a serious problem that even the school doesn't know yet what to do. The teenagers, they're going to have issues. And those issues are issues basically that are going to mount up. They're going to sums up. And the community has to really embrace that and know what to do. Well, the other thing that I just told you that I'm a pastor, so we have a question as well, who's dealing with these things, with these problems? It's not just the local community. At IFC, you name it, we have to face it. We have to deal with all that. And yes, the confusion is still there. We try to see if we can understand the culture. We try to be culturally competent. We try to do culturally responsive intervention. We do all that. But at the end, we realize one other thing. There is a problem that comes to us, it's also spiritual. It's not psychological. It is psycho-spiritual. But it takes a special someone to really understand what seems to be going on. You need to have a theological competence to understand doctrine, to understand church, to understand living in community, to understand what it means to be a person of faith. And then at the same time, to try to understand when is it a psychological disorder? What do you do with it when it comes? And how do you address it? And we began to have some distress on our part as providers. We do not have the resources to support them. Many of the groups that exist in the community or in the church, they don't have the resources. They don't have the money. They cannot pay someone to sit there and to address these problems when they come. And they come every day. We have, among the immigrants, people who come, they don't trust the psychologist. They don't trust the school. They don't trust the police department. They don't trust anybody. But they do trust their pastor. They do trust a family member. They do trust somebody that can take them and carry them to the next level. We come to realize that depression is something that is relational. You have one person here who is depressed, mom is depressed, the child is also depressed. The behavior that you see is a reflection of what he or she is dealing at home. So the depression is coming right from home. So how do we go about addressing it? So IFC put forth a symposium that brought out the task force. And the task force had to answer a few questions and a series of things that we have in our community that we have to deal with. It's the problem that every one of us we are dealing with. That we don't have enough resources. There is no money to pay somebody to do things, or we have to deal with something called the insurance company. The insurance is a serious problem. They want diagnosis. And just like I told you, there is a diagnosis that is called immigrant mental health. That is not in the DSM. It used to be NOS. It's no longer. They don't pay for NOS, not otherwise specified. They don't pay for that. You have to give a diagnosis. And sometimes when you go, then you say, okay, what do you do in order to make sure that this person who's desperately need the assistance, in order that they may have the assistance. You have community ministries. My wife lead a ministry that is known as the Sentinels. We go directly where the problem exists. We sit down with a sister, with a brother who's dealing with a problem that he could not sleep over last night. It's just a problem for a one period of time, but he just needs assistance. And if you intervene at the right time, the right moment, you can stop a disaster. You just have to be there. Well, we realize that there is something called ministerial presence. And that's what the rest of us clergies, we do. Sometimes we receive a phone call at 1 o'clock. Now, if you call in Dr. Celestin at 1 o'clock, I should call the mayor's office, don't you think? Instead of 911. So you should call the mayor, not me. But the pastor, they call you anytime. Sometimes they come with the problem. You hear the bell, and then you say, ooh, at that time, Then you find out, okay, they bring the problem to your doorpost, and you have to address it. Then the task force at FC really asked the question, what then shall we do? In order to really create this sense of urgency in the part of the policymakers, for them to be sensitive, to realize that the money that they're going to spend, as they're going to make the budget for the next fiscal year, how they're going to make sure that there is equity in the way that the money is spread in order to have enough workers. We are doing a very good thing these days on creating what is known as community social workers. It's very good, but that's what they are, community social workers. We also need psychotherapists. We need the counselors. We need people who can go deeper in the matters, people who can sit and understand how the mind functions, and to answer the question, why do you do what you do? And as a result of what you do, how do we go about modifying your behavior? Just like I mentioned, the young kids. Whatever mom is going through, this child is going through the same thing. Whatever dad is going through. And as you know, many times among the immigrants, there is no dad. So these people come and they are part of the community. I said to a good friend who happened to be a deputy in one of the police stations, he made a comment and I said, well, we have to find a way to know what we're going to do because these people are not going anywhere. Now, I don't want to be political, okay? But they're not going anywhere, you understand? They are in the community. You have to understand that they're part of the community and whatever decision you're going to make, you have to consider them. That's where the church comes. These folks come to church every Sunday. Every weekend, we have them. We deal with them as well. So what we are saying is that as you are making decisions to serve, you also need to have a holistic approach. We call it eclectic. Look at everything, because everything matters. Sometimes you think that's not it, maybe it is. Or maybe it's not really, but it is the only step that if you take it, then you solve a lot of problems. It seems you tell me I said enough. Is that the case? So, stop for now.
Thank you, Dr. Celestin. Does anyone have any questions? We're just going to take a few questions. Dr. Monasterio has told me we're coming to an end. Does anyone have any questions for our panelists? Yes, sir.
Yeah, I've been sitting here for, 3-4 hours. I heard a lot of good things. There's one word to me that is missing: prevention.
That's a very good point. Prevention basically said that you have the capacity to foresee, see things before it happens, and then you take measures in order to make sure it doesn't happen. That's exactly what I should have talked to you first, then I would say that. Then I would sound very smart if I talked to you first. A lot of things happen because we fail to understand what seems to be going on. And then for us to take measures so that it doesn't get to the next level. We often wait for things to happen. And I'm glad you say that is because we had to deal with the police department a very long time. So many times, the police department received phone calls, and then the officer came and said, well, there is no problem here. Because they're waiting for a crime, they're waiting for something that they can put fingers in, and then they're waiting for something. But the aspect of trying to make a decision so that this doesn't get there, they're not looking at that. The young folks that I'm mentioning here who are right now in middle schools, that is what the city needs to start working on, prevention. Let's go and start looking at them where they are right now. See what they lack. Why is it this kid is not doing too well in school? And then take the measures. Begin to do things. Treatment plan works, but usually that's what we do. We do work with treatment plan to prevent the worst. There is a level that the client may be stable. He's not going to get better. But we work at a level as well to make sure that he's not regressing. Right? That's the measure of prevention. What are we doing? What are the steps that we need to take and put in place in order to make sure that the unintended does not happen? And that requires resources. And I think that's what needs to be taken place. Pay attention who we have in the community, and then take steps to avoid the worst.
Good point. Should have said the word prevention. In primary care, we try for everything to be prevention. Obviously, we try to avoid the escalation of a medical condition. We, as an example, at the health centers, that we universally screen all of our patients for not only medical conditions, their blood pressure, their weight, but we also universally screen for health-related social needs to understand their access to food, to transportation, to employment, to education. We universally screen for depression, and substance use. And the reason that we universally screen for these things as measures of primary care is because we are trying to prevent, for any patients who seek primary care through us, we're trying to identify areas of potential vulnerability and intervene at that moment before it exacerbates or becomes a diagnosis. One initiative in the point around youth mental health, one example is that in addition to the universal screenings, we introduced a program that we call Universal Touch, which means that for every child who comes in for a well child visit within the years of 0 and 3, so 0 to 3 years, we include an engagement with somebody from our social services and behavioral health program. Not because something popped on a screening, but because that is primary care. The same way as the baby will get immunizations, the family will get an engagement with a community health worker and a behavioral health clinician. If we miss that baby in that visit, maybe not both the community health worker or the behavioral health clinician, maybe they can't both come in at that visit because there's just too much volume, so we'll have the community health worker who is also has received extra training in how to determine if a family might be at risk for developing a condition. One of the things I was very excited about hearing that I haven't heard a lot of in conversations about public health actually from clinicians other than early childhood mental health people is ACEs, is the concept of ACEs. I used to speak about this a lot. I'm an ex-early childhood mental health clinician, and I say ex because I haven't kept up with the research. So I really couldn't practice right now without going back for that. But many years ago, I used to work seeing young babies and their primary caregiver, and was seeped in the conversations around adverse childhood experiences. And that so much of what we do at BNHC, and that so many of the agencies in the community do, is that how to wrap around our families to prevent diseases from getting worse. There is still so much work to be done, and we know it because we see so many adults, young adults, middle-aged, older adults who are struggling with cardiometabolic disease that end up at BMC South. From us to BMC South, that end up with depression in high school, that end up with so on and so forth, right? So there is still so much work to be done. That is some of the philosophy that we take and the practice that we take around prevention.
So as a public health physician, I want to add a few things. So in public health, for example, in the study we presented earlier on, the community health assessment, if you scan the code and you download that document, you will see that primarily our assessment was driven from two angles. From an angle of what we call social determinants of health, and then the health outcomes. So why do we want to look at social determinants of health? We look at those social determinants of health from an angle and intention of prevention, because we know that these are the drivers of the morbidities that we see on the other end. For example, you see obesity, you see alcoholism, you see as unfavorable health outcomes, you see youth mental health deterioration as unfavorable outcomes. But when you look at the drivers, then you now begin to consider the issues of homelessness, the issues of substance abuse, the issues of the social adolescence health, let me just put it that way. the social and psychological ambience in which our children are growing up. Is that ambience promoting a culture of violence? Is that ambience promoting a culture of self-stigma, for example? If it is promoting any of these two, it will definitely lead to an outcome that will not be healthy. If it's promoting a culture of violence, then you see an increase in violent behavior. If it's promoting a culture of stigma, you see an increase in depression. So, on the other hand, also, we look at issues of homelessness and housing. Homelessness and housing will drive overcrowding, for example, as there are many studies that show you children who grow up in an overcrowded environment, which some want to call a slum, or let's avoid that word, they tend to be higher incidence of violence. So there are some things that you cannot really address from a public health perspective without looking at the social determinants of health, because you want a perception, you want a clear perspective of what is driving these unfortunate health outcomes so that you can nip it in the bud. And that is basically what we call prevention. So if you look at that study, it might not have used that word directly, but of course you look at it, you see that the understanding is we're looking for the drivers of the unfavorable health outcomes with the intention of mitigating those drivers so that the unfavorable health outcomes will be controlled.
That part of prevention also is personal responsibility. It's easy to look at the system as a whole and what is who doing, what is that organization doing. But there's a high degree of personal responsibility. If I do not want to have lung cancer, maybe I should stop smoking. So I need to take personal responsibility for some of the things. I need to rearrange my life to keep physically active, to engage in adequate nutrition as I am able to. That contributes to that prevention. It's not all somebody else doing it for me, but taking personal responsibility for my own well-being.
Everyone that comes and goes from the hospital is screened for social determinants. We go through their prevention. Same thing for the emergency department. Same thing for the clinics for that. It's tricky on what do people do when they get that information. So something as simple and basic as smoking, yes, they're given education on that and resources to help. But it goes to, are you safe at home? Do you have substance abuse? Everything is covered. This is a big push across the nation for that. The information is there. The trick is what happens next with follow-up. And it does come down to a lot of choices that people have to make and resources where we can send people to.
And I want to thank Dr. Monasterio for inviting me and my colleagues here today. We're excited to continue the partnership through the Public Health Excellence Grant for years to come.
First, let me say thank you to our Chief Medical Officer, Dr. Whitman, for a great presentation. I never do this. When we called for Commissioner Goldstein, he was not going to be available because he's on vacation, but Dr. Whitman jumped right in, and thank you so much for being here, and all the team from DPH. We also want to acknowledge the media that have come to represent or to record the event today. We have BCA or Brockton Community Access, and thank you so much for being here. And thank you so much. We have MTV and Info Haiti, Mr. Kajis, thank you for coming to the event. I also would like to acknowledge Dr. Herman. When I came in September 1st, 2020, I didn't know what I was jumping into because that was the peak of the pandemic, COVID pandemic, and he was there with Mayor Sullivan, and he has worked through the pandemic season with us. So thank you, Dr. Herman, for all your support. So we hope we continue to work together. And also, I want to give another hand to our panelists. Thank you for all the contributions. I have many acknowledgments to make, but I want to make it short because I know today is Friday and you want to head home. But I would like to, wherever my staff is, I know at 4:30, basically beyond 4:30, we have to go overtime, and I don't have a budget for overtime. So I want to acknowledge the rest of my staff here. We have over there one of the public health nurses, Jessica Cabilles, and Lynn is not here today. Then we have another nurse coming in to fill in the vacancy that we had. And then we have Jacinia Urea and Eunice Barbosa Bailey. And of course, we have Dr. Sebastian, Commissioner for Health and Human Services, who is still interim. We're hoping that things will move ahead. We have other staff members who are not here today, but we have a small staff, but we try to make miracles with them. I also would like to acknowledge our vendors who are here today. Unfortunately, I won't have the time to mention each one of them by name, but we did list them on the program, except for one that we received last. That is the Haitian Community Partners with Ms. Marlene Amide right there. But the rest of them, you can read it right here. So thank you so much. Oh, I see a member that did not stand. This is a physician, also graduated from medical school in Haiti and has worked, but has moved here. And Dr. Toussaint, would you stand also, please? And let me see, they're in hiding. I think that's about the members, all the members from my staff who are here with us today. So we can allow our mayor-elect to give you greeting remarks. And we have Mayor-elect Honorable Moses Rodriguez with us here today. Please, Mayor, please come forward so that we can give. And as he comes, we want to thank Deputy Commissioner or Interim Commissioner, Mr. William Forty, who is the head of building and inspectional services, along with other staff. And I don't know who else is here. Oh, IT also. We thank IT for being with us here. Nicholas is here with another member. So basically, we want to say thank you to all of you who have come. And now, Mayor-elect Honorable Rodriguez, Moses Rodriguez.
I don't know what to say because Dr. Montessor, I guess, has done all the thinking, but I honestly just want to thank again everybody that's here on behalf of our city, on behalf of our current mayor, on behalf of the current city councilors and school committee members, on behalf of those that are coming in January. We truly, truly, truly appreciate the work that's done by all of you and all the agencies that were here. Brockton, when you sit down and think about it, we are the mecca of medicine south of Boston. When you look at, this is where all the hospitals are, this is where the best health center in the country is at. And Maria, I'll expect that check. But it truly is. I mean, you've got great churches, great community organizations, great hospitals, a great health center, and many, 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 many health providing individuals in this community. So I think the only thing that I would say is perhaps next time that we're doing this, let's not do it on a Friday. And perhaps not in the afternoon as well. Maybe do something in the middle of the day so some folks can actually come, because I think this was a worthwhile undertaking in a sense. So, but again, I just...
I'm taking there.
You got it? All right. So I just want to leave it here that, this is a great city. We have our little problems like every other city has. The diversity in this city is something that I think Boston needs to look and take us a little more serious. Where's the deputy commissioner? She's over there. Okay. She's acting like she's not listening. You know how those people are. But we need, yeah, absolutely. But we need, Boston to take us and take our needs a little more serious. And when I say Boston, I'm talking about state government. Because of the necessities that this community has, the fact that we have the largest of a lot of things in this community. This is the most diversified city in the Commonwealth. As a matter of fact, we're the only majority black community in the entire New England states. So that alone should tell us some of the health disparities that exist out there, that we need to take this city a little more serious and put resources behind it as well to help us help our citizens. I remember what happened in COVID. We struggled here because our community just was not as informed as some of these other communities. I think for the longest time, we were the second worst community in Massachusetts in terms of infections. I think somebody actually told me not too long ago, I think it was Eves, that mentions that the Cape Verdean community is one of the highest communities when it comes to opioid overdoses and death in the entire Commonwealth in the sense. So those are things that are, and I keep saying that we have things provided in a variety of different languages and stuff, but some of these other mega communities that we have are often forgotten. So we need to kind of make sure we put the resources in the right place so we can provide the services that our community truly, truly deserves. But again, I didn't come here to gripe. I'll do that after January 5th. I just wanted, again, just thank you guys all for being here, for doing the work that you did throughout the periods and the work that you'll be doing going forward. So thank you, and please continue to believe in Brockton, and please continue to provide the services that you guys provide in our community. Thank you.
So basically, we officially end